Started. All right. So good afternoon, everyone, and welcome to Health Coverage Insurance and Financial Services. And are we all set, Edna?
Feel like we have a.
Yeah, we have an
We have an
echo
echo.
going on here.
Echo, yeah.
I I don't need to hear my voice twice.
Yes, sir.
That's it? All right. Thank you very much. So this afternoon, we have two confirmations hearings, then we're going to have a presentation of a report, and then we'll have a public hearing on LD 1890. Before we get started, we will do introductions and we'll start way down there. Representative Chimino.
Thank you. Thank you, Madam Chair. Good afternoon, everybody. Thank you for being here today. I am Representative Mary Grace Chimino. I represent the towns of Bridgeton, Harrison, and Denmark.
Representative Mastracchio.
Good afternoon. I'm Anne Marie Mastracchio. I represent House District 142, which is part of the city of Sanford and the village of Springfield.
Good afternoon, everybody. I'm Paul Flynn. I represent District 63, which is Winslow, Albion, and Freedom. Thank you.
Good afternoon. I'm Rolf Olson. I represent District 86, which is Raymond, Casco, Fry Island, and a bit of Poland.
Good afternoon. My name is Bob Foley. I represent House District 145, which is most of the town of Wells.
Good afternoon. Happy New Year. My name is Christy Matheson. I represent District 151 and I serve as the House Co-Chair.
And I am Donna Bailey. I represent Senate District 31, which is Buxton, Old Orchard Beach, and Saco, and I serve as the Senate co-chair. So the first order of business is going to be a confirmation hearing for Amanda Burgess of Auburn for appointment to the Advisory Council on Affordable Health Care. This is a public hearing of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services for the purpose of considering the nomination by the Senate President of Ms. Amanda Burgess of Auburn for appointment to the Advisory Council on Affordable Health Care. Under the law and joint rules of the legislature, this committee is required to hold this public hearing and to recommend confirmation or denial of the nominee by majority vote of the committee members present and voting. As chairs of the committee, we will then send written notice of the committee's recommendation to the President of the Senate. The committee will hear testimony from and have an opportunity to question the Senate President or her representative, the nominee, and any other persons present who wish to speak for or against the nomination. Persons testifying at the public hearing today are advised that the hearing is live streamed and may be seen and heard by persons watching online, and that a recording of the meeting will be archived. Pursuant to Title III, Section 157 of the Maine statutes, which requires that there be an affirmative motion to recommend confirmation of the nominee, the chair recognizes Representative Matheson for purposes of making such a motion.
I move that the Joint Standing Committee of Health Coverage, Insurance, and Financial Services recommend confirmation of Miss Amanda Burgess of Auburn for appointment to the Advisory Council on Affordable Health Care.
Thank you. And do we have a second?
Second.
Seconded by Representative Foley. And a copy of the statutory requirements for this position is available at the rostrum. I will now recognize David Domino for the purpose of making a statement concerning this nomination.
I apologize, but I look a little nervous. This is my first time doing this. Good afternoon, Senator Bailey, Representative Matheson, and esteemed members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. For those of you who don't know me, my name is David Domino, and I work as the Constituent Services Manager for the Senate President, and I am responsible for overseeing board and commission appointments in her office. On behalf of President Daughtry, I am pleased to introduce Amanda Burgess to appointment on the Advisory Council on Affordable Health Care as a representative on health economics and research. Amanda has over a decade of experience in public health that she can apply to this council and its work. She pursued her interests in infectious disease and access to healthcare services as a research associate at USM's Cutler Institute and a grant specialist at Partners in Health. During her work with the Cutler Institute, she directed research projects related to access to care with a focus on rural health and telehealth. She also has experience conducting quantitative and qualitative analysis using various data analysis softwares. She has written or contributed to 34 academic papers related to the medical field and research, and is currently a reviewer for both the Journal of Rural Health and the Journal of Substance Abuse Treatment. Amanda has worked extensively on studying rural healthcare and finding means to expand healthcare to underserved areas in Maine. Given her years of research experience and extensive published research, we look forward to seeing her contributions to this council.
Thank you, and you did great.
Thank you.
Any questions from committee members? Seeing none, thank you very much. And I would now recognize Ms. Amanda Burgess for the purpose of making a statement concerning this nomination. Welcome.
Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. My name is Amanda Burgess. I live in Auburn, and I'm here today to discuss my nomination to the Advisory Council on Affordable Healthcare. My personal and professional interest in the issue of access to healthcare services began shortly after I graduated from college, when, as an intern, I was given the task of answering the phone in a congressional office. Many of the folks I spoke with from Maine and beyond were calling because they were at the end of their ropes, trying to access healthcare for themselves or a loved one. I listened to their stories, heard their frustration and their anguish, and was deeply moved. Since then, my work has pivoted around the question of how to ensure access to needed healthcare services. At the University of Southern Maine, my research has spanned a variety of methodologies and health-related topics, including quantitative and qualitative assessments of access to care, particularly in rural areas, telehealth services and implementation, and infectious disease. The research I've done related to affordability is rooted in the experiences of the individuals that are in need of care. Are people cutting pills in half to make their prescriptions last longer? Are they foregoing their annual physical due to cost? Are cost-sharing requirements causing them to restrict spending on other essentials like food or heating oil? I believe these types of questions are a key component of comprehensively assessing affordability of healthcare services. As a member of the Advisory Council, I would bring my expertise in rural health and health services research, as well as my professional connections at the University of Southern Maine. I would be honored to serve the people of Maine in this capacity, and thank you for your consideration.
Thank you. Questions from committee members? Seeing none, thank you very much.
Thank you.
And we will now take comments from persons attending this hearing who wish to speak for or against this nomination. Anyone who has a written statement but who does not wish to speak should have submitted the statement with the committee clerk prior to today's hearing. All such statements shall contain the name and residence of the person who prepared the statement. A copy of each written statement presented to the committee at this hearing will be made available to the nominee prior to the committee's vote, and the nominee will have an opportunity to respond to the written comment. Edna, I don't think we've received anything, have we, in writing? Oh, no. And I was just asking if we received any comments. You're ready, huh?
Cut to the chase.
I'm getting there. I'm getting there. I was just asking if we had received any written comments.
No.
Thank you. Those who wish to speak should observe the following. Please sign in on the testimony sign-in sheet at the podium. Please speak from the rostrum and state your name and place of residence prior to presenting your testimony. Persons participating electronically will be called upon by the chair, at which time they will be promoted to panelist status in Zoom and can be seen and heard. Only comments concerning the suitability of this particular nominee for this particular position will be considered in order. All other comments will be considered out of order. Please remain at the podium after you complete your statement so that members of the committee may have an opportunity to ask questions. First, is there anyone present who wishes to speak in favor of the nomination? Anyone present who wishes to speak against the nomination? Is there anyone else who wishes to speak in any capacity on the nomination? All public comments having been taken, the committee will now proceed as follows. Review any additional written comments, received by the committee. We have none. Vote on the nomination and notify the President of the Senate pursuant to Title III, Section 157, and the joint rules. The vote must be taken within 35 days from the date of the written notice. The hearing by the Standing Committee on Health Coverage, Insurance, and Financial Services for Ms. Amanda Burgess of Auburn for appointment to the Advisory Council on Affordable Health Care is now closed. In accordance with the law, the committee may not take the vote on this nomination sooner than 15 minutes after the close of the public hearing unless all committee members who are present agree. At this time, therefore, I will inquire whether any member present objects to proceeding to take the vote immediately. Any objection? Okay, if no objection, the pending question before the committee is that the Joint Standing Committee on Health Coverage, Insurance, and Financial Services recommend to the Senate of the 132nd Maine Legislature that the nomination of Ms. Amanda Burgess of Auburn for appointment to the Advisory Council on Affordable Health Care be confirmed. In accordance with 3 MRSA Chapter 6, Section 157, and the joint rules, the vote will be taken by the yeas and the nays. A vote of yes will be in favor of recommending confirmation. A vote of no will be against the motion to recommend confirmation. Is the committee ready for the question? Edna's ready. The committee clerk will call the roll, please.
Thank you. Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Shamino.
No.
Representative Shamino, no. Representative Flynn.
Yes.
Representative Flynn, yes. Representative Foley.
Yes.
Representative Foley, yes. Representative Mastracchio.
Yes.
Representative Mastracchio, yes. Representative Olson.
Yes.
Representative Olson, yes. 7 members of the committee having voted in the affirmative and 1 in the negative.
All right, thank you. 7 members of the committee having voted in the affirmative and 1 in the negative. It is the vote of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services that the nomination of Ms. Amanda Burgess of Auburn for appointment to the Advisory Council on Affordable Health Care be confirmed. Congratulations. These are utilities, you know that, right?
Yes.
And do we have Richard on Zoom? Mhm.
The same way with this. They're gonna call people in the office to basically.
Thank you. Edna, do we have Richard on Zoom? Dr. Evans? Great. We want to bring him forward.
We hit 20.7. I think that's 15. Is there a cutoff?
Great. Thank you. Welcome, Dr. Evans. This is a public hearing of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services for the purpose of considering the nomination by the Senate President of Dr. Richard Evans of Dover Foxcroft for appointment to the Advisory Council on Affordable Health Care. Under the law and joint rules of the legislature, this committee is required to hold this public hearing and to recommend confirmation or denial of the nominee by majority vote of the committee members present and voting. As chairs of the committee, we will then send this written notice to the committee's recommendations to the President of the Senate. The committee will hear testimony from and have an opportunity to question the Senate to question the Senate President or her representative, the nominee, and any other persons present who wish to speak for or against the nomination. Persons testifying at the public hearing today are advised that the hearing is live streamed and may be seen and heard by persons watching online, and that the recording of this meeting will be archived. Pursuant to Title III, Section 157 of the Maine statutes, which requires that there be an affirmative motion to recommend confirmation of the nominee, I recognize Senator Bailey for the purposes of making such a motion.
Thank you, Madam Chair. I move that the Joint Standing Committee on Health Coverage Insurance and Financial Services recommend confirmation of Dr. Richard Evans of Dover Foxcroft for appointment to the Advisory Council on Affordable Health Care.
I'll second that nomination.
Thank you. A copy of the statutory requirements for this position is available at the rostrum. I recognize the, who are we? Yes, Dr. Richard Evans, Representative David Domino. Yeah, sorry about that, David. For the purpose of making a statement concerning this nomination.
I apologize again. This first part's going to sound familiar. Good afternoon, Senator Bailey, Representative Matheson, and esteemed members of the Joint Standing Committee on Health Coverage Insurance and Financial Services. My name is David Domino, and I work as the Constituent Services Manager for the Senate President, and I am responsible for overseeing board and commission appointments in her office. On behalf of President Daughtry, I am pleased to introduce Dr. Richard Evans to appointment on the Advisory Council on Affordable Healthcare as a representative on the interests of older Mainers. Dr. Evans brings years of experience, both in government and in the medical field, that make him an asset for this council. He is the former president of the Organization of State Medical Association Presidents, is a former president of the Maine Medical Association, a trustee and governance committee member for the Maine Health Access Foundation, and is a member of the Maine Medical Association. These roles alone are impressive, and yet they only scratch the surface of his experience and career accomplishments. He is the recipient of the American Medical Association Outstanding Government Service Award while he was a member of the Maine House of Representatives, which is one of the American Medical Association's highest honors. He also received the President's Award for Distinguished Service by the Maine Medical Association, as well as the Outstanding Leadership and Service Award from the Organization of State Medical Association Presidents. During his time in the legislature, he advocated on issues including substance use reform, physician workforce development, and bolstering health coverage access. He established the Accidental Drug Overdose Review Panel, as well as passed legislation to simplify the enrollment process in Maine care of a marketplace health plan. With his years of experience and wealth of knowledge in looking out for the best interests for Maine people, we look forward to seeing his contributions on this council.
Thank you, Mr. Domino. I'll ask if the committee has any questions of Mr. Domino at this time. Seeing none, thank you for your time. Now I'd like to recognize Dr. Richard Evans for the purpose of making a statement considering his nomination. Welcome, Mr. Evans. We can't hear you, Dr. Evans. I think you need to turn your microphone on.
Thank you. Can you hear me now?
We can, thank you.
Okay. Thank you. Good afternoon, Senator Bailey, Representative Matheson, esteemed members of the Health Coverage Insurance and Financial Services Committee. My name is Dr. Richard A. Evans from Dover Foxcroft, Maine. It comes as I am here today to discuss with you my nomination to the Advisory Council on Affordable Health Care. It comes as no surprise that Maine faces significant challenges in health care affordability and quality, driven by its aging population, high costs, and access issues, particularly in rural areas. Healthcare costs have risen substantially, outpacing income growth, resulting in 1 in 3 Mainers having reported delaying or skipping necessary medical care or prescription drugs due to the lack of expense. There's a greater demand in Maine for costly care, including long-term care services that tend to be higher than the national average. We have significant workforce shortages, rural access disparities, where 2/3 of Mainers live in rural areas, fewer physicians, and high hospital closure rates, which can mean long travel distances, especially for maternity care. We have high market consolidation where large health systems acquire smaller providers, leading to higher prices and fewer choices, low reimbursement rates, and cost shifting to consumers. Health disparities also continue to be impediments to access to care. As you are aware, the Advisory Council on Affordable Healthcare was established as an independent, nonpartisan input to the Office of Affordable Healthcare on systemic issues and data-driven solutions regarding the cost and quality of healthcare in Maine. It serves as a formal advisory body to ensure that diverse stakeholder perspectives inform the state's healthcare affordability strategies. I am seeking to be of service to the people of Maine, the Advisory Council, and to the Office of Affordable Healthcare because affordable, high-quality healthcare is a foundational aspect of the economic and social well-being of every man. As a physician and surgeon, I have seen firsthand the consequences when people delay care because of costs. As a former legislator, I understand how policy decisions translate into real-world outcomes. The Advisory Council plays a critical role, in bringing data, experience, and diverse perspectives together to inform sound policy. My experience allows me to contribute constructively, objectively, and with the best interests of the people of Maine at the center of every recommendation. My clinical background keeps me grounded in patient realities. I understand how coverage decisions affect access, outcomes, and long-term costs. Physicians are trained to weigh evidence, assess risk, and prioritize prevention, skills that translate directly to health policy. My goal is always to ensure that policy recommendations improve care delivery while avoiding unintended consequences that drive up costs or reduce access. During my many years of service, I am positioned to bring a unique combination of clinical expertise, policy knowledge, fiscal management, and leadership to the council, experiences that I have found to be of benefit at both regional and national levels. I understand Maine's healthcare challenges, both from the bedside and from the policy-making table. At a time of significant uncertainty and change, steady, informed, and collaborative leadership is especially important. In my view, health is the first wealth. It is not a partisan issue. It is an issue where no one is left behind, especially the most marginalized in communities. I see the role of an advisory council member to be one of guidance and unwavering support for the Office of Maine Affordable Health Care. I continue to this day to make it my priority to ensure that every person, not just in Maine, but across this nation, has full and complete access to affordable health care. I have continued these efforts not just on a state level, but also on regional and national levels. I have been one of Maine's 2 delegates to the American Medical Association since 2001 and continues to function in that capacity today as Maine's senior delegate to the American Medical Association. My guiding principle has always been patients first. While I have served in leadership roles within organized medicine, those roles have focused on ethics, access, and equality, not self-interest. The Advisory Council's purpose is to provide objective, data-driven guidance. I fully respect its nonpartisan and independent mandate and would approach every issue with transparency, evidence, and a commitment to the public good. The Advisory Council's role is simply that, advisory, not operational. It should provide independent analysis, elevate stakeholder perspectives, and help identify evidence-based solutions. The Office of Affordable Healthcare is responsible for implementation. A strong, respectful partnership grounded in data and transparency is essential for success. Of grave concern to me is the current federal cuts to Medicaid, Medicare, and the expiration of the extensions at the federal level to the Patient Protection and Affordable Care Act. These cuts will severely hurt Maine citizens. Medicaid will be cut by $3 billion over the next decade, placing up to 34,000 Mainers at risk of losing Maine care coverage. Rural hospitals will have to curtail or close certain services entirely, and they will not be able to absorb the cost of care for the uninsured. The proposed increase in tax cuts for the wealthy in Maine rises from $37,000 to $59,000 annually, with essentially no benefits for the bottom 40% of wage earners. This bill essentially blows a hole in the state budget of approximately $190 million. None of us have all the answers. The issues are complex and must be analyzed with reason, logic, and science. We are at a point where we must look outside the box, as the federal government has proven itself not to be a reliable partner when it comes to ensuring affordable health care for every American. These are the same issues that we have been fighting at the American Medical Association and at the Organization of State Medical Association presidents. Maine must prepare proactively. That means careful analysis of fiscal impacts, exploring state level and regional solutions, and prioritizing protections for the most vulnerable population. The state cannot replace federal funding entirely, but it can mitigate harm through smart policy design, collaboration, and innovation. Decisions by the council should be driven by measurable outcomes, cost growth trends, access indicators, workforce capacity, health disparities, quality metrics, and patient experience. Data must be transparent, comparable, and actionable. Equally important is listening to frontline providers and patients to understand what the data may not fully capture. If confirmed, I see my role as an advisory council member to be one of guidance and unwavering support, with appropriate and effective recommendations for the Office of Affordable Health Care to be able to effectively carry out its duties and responsibilities for the betterment of the health and well-being of all Maine citizens. I view appointment to the council not only as an honor, but as a duty and a responsibility in support of the health and well-being of all Maine citizens. If confirmed, I will approach those duties and responsibilities with humility, diligence, and unwavering commitment to improving the health and well-being of all Mainers. I thank you for your attention and time. And with that, I yield back to the chair.
Thank you, Dr. Evans. And I'd like to open up the floor to any member of the committee that has questions of the nominee. Seeing no questions, I'll now take comments from persons attending the hearing who wish to speak for or against this nomination. Anyone who has written statement but who does not wish to speak should have submitted the statement with the committee clerk prior to today's hearing. And I understand. Thank you. All such statements shall contain the name and residence of the person who prepared the statement. A copy of each written statement presented to the committee at this hearing will be made available to the nominee prior to the committee's vote, and the nominee will have an opportunity to respond to the written comment. Those who wish to speak should observe the following. Please sign in on the testimony sign-in sheet at the podium. Please speak from the rostrum and state your name and place of residence prior to presenting your testimony. Persons participating electronically will be called upon by the chairs, at which time they will be promoted to panelist status in Zoom and can be seen and heard. Only comments considering the suitability of this particular nominee for this particular position will be considered in order. All other comments will be considered out of order. Please remain at the podium after you complete your statement so that members of the committee may have opportunity to ask questions. First, I'd like to offer any person present who wishes to speak in favor of the nomination. Is there anyone present who would like to speak against the nomination? Is there anybody else who wishes to speak in any capacity on the nomination? All public comments having been taken, the committee will now proceed as follows. Review any additional written comments on the nomination that have been received by the committee. Vote on the nomination and notify the President of the Senate pursuant to Title III MRSA Section 157 and the joint rules. The vote must be taken within 35 days of the date of the written notice. The hearing by the Joint Standing Committee on Health Coverage Insurance and Financial Services for Dr. Richard Evans of Dover Foxcroft for appointment to the Advisory Council of Affordable Healthcare is closed. In accordance with the law, the committee may not take the vote on this nomination sooner than 15 minutes after the close of the public hearing unless all committee members who are present agree. At this time, I'd like to inquire whether any member present objects to proceeding to take a vote immediately. Seeing no objection, the pending question before the committee is that the Joint Standing Committee on Health Coverage Insurance and Financial Services recommend to the Senate of the 132nd Maine Legislature the nomination of Dr. Richard Evans of Dover Foxcroft for appointment of the Advisory Council on Affordable Healthcare be confirmed. In accordance with 3 MRSA Chapter 6, Section 157, and with the joint rules of the 132nd Legislature, the vote will be taken by the yeas and nays. A vote of yes will be in favor of recommending the confirmation. A vote of no will be against the nomination of recommended confirmation. Is the committee ready for the question? Committee clerk can call the roll call.
Thank you. Senator Bailey?
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Alford?
Yes. Yes.
I'll turn my, oh, I think it might be, I'll turn.
There you go.
Yes.
Representative Alford, yes. Senator Baldacci?
Yes. Yes.
Senator Baldacci, yes.
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 Representative Boyer, yes. Representative Sabino?
No.
Representative Sabino, no. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
Yes.
Representative Mastracchio, yes. Representative Olson?
Yes.
Representative Olson, yes. 9 members of the committee haven't voted in the affirmative.
Representative Clucci.
Oh, I had you, I'm sorry. Okay, Representative Clucci.
Yes.
Representative Clucci, yes, thank you. 10 members of the committee haven't voted in the affirmative and 1 in the negative.
10 members of the committee having voted in the affirmative and 1 in the negative. It is the vote of the Joint Standing Committee on Health Coverage Insurance and Financial Services that the nomination of Dr. Richard Evans of Dover Foxcroft for the appointment of the Advisory Council on Affordable Healthcare be confirmed. Congratulations, Dr. Evans.
Thank you.
Representative Boyer, are you doing the presentation or?
Yes.
Okay, have you heard from him or have we heard? Okay, Edna or Colleen, have you heard from Senator Tipping?
I know they have confirmation there.
Oh, okay.
Across the hall? Yeah.
Yeah, because we could do the public hearing if he's not available.
I'll go back.
Which item is he going to speak?
That's the presentation. And we have a public hearing, so we could flip that. All right, so now we're going to have a presentation of the report of the commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. I don't know what committee came up with that name, but welcome Senator Tipping and Representative Boyer.
Thank you for having us. Michelle Boyer, I represent House District 123, which is most of Cape Elizabeth.
Sure. Mike Tipping, Senate District 8 in Penobscot County.
So we're going to start today just going over the members that were on the commission, and you can find it in the packet. It's Appendix B of your report. So from the legislature, it was myself and Senator Tipping, Representative Foley, feel free to chime in, and Senator Hagan as well. We also had Susan Sheff, who was a member that represented healthcare providers, Kate Endy, who many of us in here are familiar with, but from Consumers for Affordable Healthcare, Adam Prescott, a member of the public who's a lawyer. We also had Trevor Putnocki, another familiar face in this committee. Marie Vanneau, who represents hospitals, Angela Cole Westhoff, who represented a statewide association of nursing homes or long-term care facilities. Chris Ossenfort, we all know in this committee as well, representing insurers. Christina McGuire, also representing hospitals. Roger Poitras was representing independently owned specialty healthcare practices. Mr. Monteo, William Monteo, who we all know from the department. And Meg Garrett Reed, another familiar face, Executive Director of the Office of Affordable Healthcare. So just wanted to go over the list so that you all had a real appreciation. We had a wide range of stakeholders available and present as we were doing our meetings. As a reminder, how we got here, the legislation that came before this committee that brought us to this commission study was LD 985, which was a bill from Senator Tipping that we did pass that prohibited private equity purchases of hospitals, and that we ended up passing it for 1 year. So in June of 2026, that piece of legislation will expire. It was also LD 1578, which was Representative Jan Dodge's bill, which looked at changing the certificate of need process for closures of services. And the third and final bill was LD 1972 from Representative Sam Zager. And that was a healthcare market oversight bill that really looked at sort of creating a process that was adjacent to certificate of need, but different than what we had done here before in the state, and was a very comprehensive overview of healthcare transactions. So just to reiterate the three pieces of legislation that brought us to this study. And one last thing I wanted to touch on before I pass it over to Senator Tipping was just on page 3 of your report, numeral 3, just what our duties were. Just to refresh everyone's memories, the duties of the commission were to look at potential changes to the state certificate of need laws, potential legislative changes to require regulatory review and oversight of substantial healthcare transactions, such as transfers of ownership or control, and also the role of private equity companies or real estate investment trusts taking a direct or indirect ownership, interest, operational control, or financial control of a hospital in the state.
And I would just say, first of all, that it was a pleasure and an honor to work with Representative Boyer and Representative Foley and the others on the commission, all of whom know way more about these issues than I do. And we heard from so many people that have, spent lifetimes in the industry of healthcare in Maine, and were able to get some of their perspectives on these issues. I also just wanted to thank the staff, Colleen McCarthy-Reed, Karen Netto, and Steve Lehman, and all the work that they've done to prepare this report and to staff the meetings. This committee gave the commission quite a broad mandate, as you've heard from the number of bills and the range of topics that they cover. A lot of our work was kind of focusing, seeing what we could accomplish with the time and the resources that we were given, and trying to get to some actual actionable recommendations out of the commission's work. So the way that we did that is by holding a total of 5 meetings. The first, we predominantly organized ourselves, and we also heard from the public pretty extensively. We had some great comment on the scope of our work and also on the importance of these issues to people across the state. At our second meeting, we began the process of zeroing in on some of these issues by bringing in some experts on some of the matters that we were considering and discussing. These included Assistant Attorney General Christina Moylan, Connecticut State Senator and Healthcare Committee Chair Senator Saad Anwar. Dr. Anwar told us both about some of the things that have happened in Connecticut in terms of healthcare regulation, as well as some of the practical matters of passing legislation on these issues. We also heard from Dr. Zero Song, who's the professor of healthcare policy at Harvard Medical School and an expert on private equity. And his presentation alone was a thesis level class on a lot of these issues. And from Maureen Hensley Quinn of the National Academy for State Health Policy. States are doing on many of these issues. Our final 3 meetings, we began proposing and then reviewed and refined our recommendations for improving the system And the report in front of you is the final product of those conversations.
And I think I would just add, Colleen and Karen and Steve have done a great job. So like the presentation that we received from Dr. Song is available on the commission's website and certainly worth looking through. It's really helpful, as are the other information that we received. So we would like to sort of take you through the recommendations that we came up with. Those start, I don't know on what page in your packet, but potential changes related to the Certificate of Need program. It is, oh, I just missed the page numbers, page 8 of your packet. So you'll see that we broke these into Certificate of Need, which we'll talk about first, regulatory oversight, and then Senator Tipping will talk about private equity and sort of our broader scope recommendations. But looking at Certificate of Need, the first recommendation we had was to increase the monetary threshold in current law that requires Certificate of Need review and approval to establish a new healthcare facility based on the estimated cost of this facility from $3 million to the 2025 amount as adjusted to reflect the United States Department of Labor, Bureau of Labor Statistics, Consumer Price Index, Medical Care Services Index, and require that the threshold amount for review be adjusted annually based on the change in that index. And this was a unanimous recommendation from the commission. Colleen, correct me if I'm wrong on that, but I think that's how this is, yeah. So happy to answer any questions or sort of just keep moving through the recommendations as we go. Senator Bailey.
So what is that amount?
What is that amount? Yeah, that's a great question.
This year it's a little over 4.2 million.
4.2 million. Thank you.
Essentially.
Thank you, Colleen. Representative Matheson.
And what's the adjustment amount? What is that? How does that price index increase what's the percentage adjustment?
It depends on what inflation is for that year, specifically within the healthcare sector.
Thank you.
And I'll say on all of these, we're going to kind of go over the bold headlines here. We assume everyone is going to read the report cover to cover. But if anyone wants to stop and go into things in more detail, we'd be very happy to.
Yeah, certainly. Our second recommendation, if there's no other questions, was to codify the voluntary guidance developed by the Department of Health and Human Services, Division of Licensing and Certification, to require that hospitals provide at least 120 days prior notice to the division of a permanent closure of a hospital's labor and delivery unit or of a change in the level of care a hospital provides for maternity and newborn services. So we learned during our work on the commission that there was some voluntary guidance that was sometimes being followed by different parties, but sometimes wasn't. And so this would codify that voluntary guidance and make it a requirement to follow that guidance.
Representative Olson.
Thank you, Madam Chair. Just curious why you defined it as only maternity instead of any, say, for example, cardiac care or whatever. Why would we separate maternity from other medical services?
Yeah, that's a great question. The voluntary guidance was tied to maternity and newborn care as it existed. And that has been, sort of something that has been an issue in our state. There was talk of expanding it to other services, but not consensus among the commission members to do that.
Yeah, maybe I'd just add that that was something we discussed. There was some energy for it, but it wasn't a unanimous recommendation. This was, the current practice that is in rule being put into, clear statute here and being expanded. And it's meant to address specifically, obviously there are lots of issues with healthcare services across the state, but in particular, the idea of a birthing center desert in certain areas and people having to travel, hours to give birth, the closures of specific birthing centers and especially, forget all the counties, but in several rural areas in Maine.
Representative Foley.
Yeah, thank you, Madam Chair, and thank you, my chairs of my committee. I do want to say that this was a very difficult discussion because the hospitals there acknowledge that making those decisions are very, very difficult and they don't happen overnight. But a concern that they expressed, and I think it's a realistic one, is that if you announce, because we talked about 6 months, and if you announce that you're going to close something, a particular service, in 6 months, you're going to lose all of your doctors and all of your nurses and all of your staff because they're just going to leave. And, those were concerns that they expressed. And I acknowledge that that is a difficult situation. But we also talked about the impact it has on the patients and that need to find those services. So it's a fine line. I think we debated 6 months. I think we talked, but I think we came to the 120 days, I think as a reasonable approach, especially to let the folks know that need to seek those other services. So, but I did want to acknowledge the hospitals do take this very serious. Each one of them spoke about how difficult those decisions are. And they don't take them lightly, obviously. So I just wanted to add that to the discussion.
Representative Mastraki.
Thank you, Madam Chair. I was just really going to say what Representative Foley said, that it is a balancing act. And that's why I appreciate that it was 120 days, because if you're pregnant and you want to know where you're going to have your baby, that's usually by the time you end up there, it's like you've got 6 to 9 months to figure it out. In this case, you don't want the doctors to leave quickly. So I appreciate that discussion happened. Thank you.
The questions, Representative Chimino.
Yeah, but what happens if the doctors leave once they hear the announcement and then there's nobody there anyway for that procedure, for the delivery?
So if I could, Madam Chair, that is, a big part of the conversation that we did have and an issue raised by the hospitals. Under the current, I believe it's 90-day notice, they said that was an issue, but they were able to make plans with those people, especially, pay arrangements over time and allow them to also, during that time, secure other employment that starts at the end of a fixed date. So they said that in some ways that was helpful. And they also felt that 120 in the end was reasonable.
Okay, further questions? Representative Harper.
Thank you, Madam Chair. I'm just curious. For this second recommendation, was there any discussion of, instead of having a cliff when the unit closes, having a transition plan that was discussed ahead of time with all the patients as to their choices if they did choose to still deliver at that hospital, where they then could go if the delivery did not happen before the 4 months was over, and assistance with making a transition plan for the pregnant women? Was there a discussion of including that in on the recommendation? I'm just curious.
Yeah.
So that was not specifically discussed. I'd say that's a great idea, and I hope that the hospitals would be doing that. I don't believe there was any impetus to put that into statute.
Any questions? No? Go ahead.
Thank you. So the third recommendation from the commission was to expand the criteria considered during a certificate of need review to include consideration of a proposal's impact on affordability and accessibility of healthcare for all Maine consumers, and provide any additional resources needed to implement the expanded scope of review. And I'll just add a little bit here. We learned during our commission meetings that our certificate of need department is really one full-time individual. So just keep that in mind as we're thinking about certificate of need in general and what it already does and what we may want to ask it to do as well. And the other thing, and I think it's laid out here in the paragraph below, sort of towards the end where it starts with because. The purpose of CON laws are focused on controlling healthcare costs and determining whether new spending on healthcare services meets the needs of the community. Sorry, I apologize. That's not what I wanted to highlight, but I think it's in here somewhere. But what we also learned during certificate of need is that is really focused on the cost to the state. So it is not focused on cost to consumers. The process of certificate of need is really focused on controlling costs to the state of Maine. And so that was the reason for this recommendation.
Questions? Representative Matheson.
Could you maybe clarify how the proposal impact would look at this affordability and accessibility? Is that something that came out of the commission? How would this be implemented?
Yeah, there was some debate around that amongst commission members. We did not flesh out exactly how. And there was conversation about how do you define affordability and accessibility. So we did not flesh that out.
Questions? Seeing none?
Great. Okay, so moving on, I'm going to take over or continue with potential changes related to regulatory oversight over healthcare transactions. So first bullet point there is to require a healthcare entity to provide notice to the Attorney General about a pending merger or acquisition. At the same time, a healthcare entity is required to notify the Federal Trade Commission in accordance with federal law and regulations. We received a presentation from the Attorney General's office, and this recommendation, we learned that there is like a uniform pre-merger notification act already available that we could create legislation around so that when a healthcare entity is providing notice to the Federal Trade Commission, that same notice would go to the Attorney General here in Maine. And one other thing to highlight, the AG's office in Maine has less than one full-time employee who works on antitrust and charities law. I just bring that to the committee's attention. There's one employee who does it about half-time, but she also had both. So charities law half-time and antitrust half-time. She also has other responsibilities within the Attorney General's office. And that's why I say we have less than one full-time employee who is working.
Questions on that? Yeah, Representative Matheson.
Was that a unanimous vote?
That was, yes. Yep, that was a unanimous vote. Okay, looking at the next recommendation, require that a healthcare entity provide notice to the state of a transaction between a healthcare entity and a private equity company, hedge fund, or management services organization. When a private equity company, hedge fund, or management services organization acquires a majority ownership interest in a healthcare entity, or a private equity company, hedge fund, or management services organization takes operational control over a healthcare entity. This one was also unanimous. And again, this would be a type of notice when this type of transaction was happening in the state.
Questions on that?
So who are they noticing at the state?
I'm not sure that we fleshed that out, whether that would go to the Attorney General or whether it would go to an additional, and that's, I think with 1972, I think the Office of Affordable Healthcare was, part of that oversight legislation. So here we didn't flesh out where that would go to.
Yeah,
If I'm remembering correctly.
I think that's great, except that we did have a specific notice to the Attorney General And it's the same that would be otherwise provided to the Federal Trade Commission.
Yeah,
Right, that was the
in
previous version.
Oh, in the previous one.
Yeah,
Okay,
that was
yes.
higher.
Yeah, I understood
Yeah.
that. That was
Okay.
clear.
Yeah,
This one is
yeah,
a
Yes.
little
Yep.
vague.
a little bit. Yes.
Representative Stracchio.
Thank you, Madam Chair. So what would happen after that note? Like, did you flesh out, like, we have a lot of things here where we say we want you to do this, but then there's no enforcement mechanism. So
Yeah.
what's the,
So I
flesh
think
out the
it'll,
follow-up? Like,
it'll
what
make sense
happens?
when we move to the next one. I think it'll make sense because that was not a unanimous vote, but there was like appetite among a majority to develop a regulatory process. So perhaps that's why this one is not as fleshed out.
Any questions?
Okay, great. All right, so the next and final one, and then you all won't have to listen to me talk any longer. Develop a regulatory process for review and approval of transactions when a private equity company, hedge fund, or management services organization acquires a majority ownership interest in a healthcare entity, or when a private equity company, hedge fund, or management services organization takes operational control over a healthcare entity. And this was a majority vote. So that we consider enacting legislation to develop a regulatory process to capture these transactions.
Representative Stracchio.
Thank you, Madam Chair. Is this in addition to the certificate of need?
Yes, it would be in addition to the certificate of need. I mean, certainly not fleshed out yet. I guess we could add it to the certificate of need. But the certificate of need, we learned during our commission meetings, they are not necessarily looking specifically at private equity and the issues that come along with that. And I hope I'm not saying that incorrectly, but that's the focus is not on those types of transactions.
Madam Chair, so you're not looking to do the same thing twice with two different, I mean, you're not going to be redundant. So they're going to look at the
Right.
certificate of need and incorporate it into that? It just
That-
seems like it would be like.
That could be an option, and I think that's something,
But that's not fleshed out. I'll be honest, I haven't read I just got this, so I'm just asking. 'cause you're
yeah, that
presenting-
is, this one is involved, is part of the potential draft legislation. Yes.
Yeah, and maybe we should say about that. I mean, I think some of these are broader in scope and might not be easily accomplished this session. We did try and pull out some pieces that might be more easily considered by the committee during this year. And we're happy to talk about those more at the end as well.
Okay, Representative Chimino.
Thank you, Madam Chair. So I know this was a majority vote, but at the same time, there were 6 members that voted against it, and then 1 person was absent and 1 person abstained. So my question is, what were the reasons why there was opposition to it?
I think there were commission members that felt the certificate of need process as it exists is sufficient. I don't know if you remember.
Yeah, I mean,
Opposition.
we both voted in favor of it, so it may not be the best to explicate those reasons,
Right.
but I would say there was concern about some of the other conversations that had been had in this committee, actually about regulatory practices previously, not wanting to open a kettle of worms there were various conversations around those lines.
What is a kettle of worms?
Good question.
Sorry. Did the commission hear of any other state that did anything similar to this?
So there are several states that have healthcare transactions oversights or are working on them. Massachusetts, and none of them are the same. Everyone is sort of taking a different approach, but also California, Minnesota, Oregon.
Yeah.
Those are all states that are, if something hasn't passed, they're working on oversight, market oversight like this.
Representative Foley.
Yeah, I was one of the votes that oppose this motion. And really, it did it only because after our discussion, I felt that we already have processes in place with the certificate of need process and also regulations that deal with nonprofits that already oversee those transactions. So it was like, this is sort of redundant and would be another layer of regulatory review that I didn't think was needed at this time. So that was the only reason I opposed that, because I thought it's already there.
According.
And I would
to the
just say,
report,
we did record you in favor of this one, so
Yeah.
important to take this into consideration here.
Could have been opposed.
I'm getting mixed messages
Yeah.
here, Representative Foley, Representative Flynn.
Thank you, Madam Chair, and thank you for the work you've done. My question, I think I have a couple of them here. The regulatory process, I thought we already had one. There is no regulatory process now, so we're going to develop one?
There is not one like this. Certificate of need is slightly
Right.
different.
Okay.
Yeah.
So then, in that proposal, develop a regulatory process, what agency would you propose would be developing that?
So the department, possibly with advisement from the Office of Affordable Healthcare, we have some model draft legislation on this one. But that's, of course, our recommendations to you all, and then you all can
Are they aware of the
make
recommendation?
changes.
Are they aware of the recommendation?
Yes.
Yes, okay, thank
Yes,
you.
we had representatives. from
Perfect,
both.
thank
Yeah.
you.
And I would just say too on that, I mean, part of that is kind of recognizing the current regulatory structure and its limitations. One guy doing certificate of need, and the focus on that, needing to stay as it is for certain reasons, and then also the need for broader oversight and regulation on some of these issues that have been raised.
Further questions? Seeing none? Go ahead.
All right, I think it's all you, Senator Tipping.
Okay, so the next section here, and we've gotten into this a little bit, but potential changes to address the role of private equity investment in healthcare. And we had a great conversation as a commission about kind of the direction of potential regulation around this. I think there was broad agreement that this was a potential issue and that we'd seen some of the unfortunate effects of this in other states. We decided not to pursue the idea of a general moratorium on all purchases by private equity, as was in the original bill for 1 year. Instead, look at some more transparency measures that would help with the understanding and regulation of these practices, and then also targeting one or two of the kind of worst practices that we're most concerned about, whether they're done by private equity or anyone else. So the first recommendation out of this, and most of these were not unanimous, and you can see in the footnotes the votes there and and considerations, but it was to expand the scope of CON review where there's a change in ownership of an entity to review and analyze the extent to which the applicant's ownership structure involves a private equity company or real estate investment trust. Require that the department contract with a consultant funded by the applicant to review and investigate the prior activities and conduct of the private equity company or real estate investment trust, and authorize the department to consult with the Attorney General. And broaden the authority of the department to impose conditions on an applicant and to conduct subsequent reviews following a conditional approval of an applicant for CON. And part of the idea here is that ownership can change over time, and it can be done kind of slowly as people buy up shares or change small parts of the ownership of an entity. And so there's a need there for greater ongoing insight into the ownership of these entities and to their conduct over time as part of the CON process.
Okay. Questions on that? Representative Clucci.
Thank you, Madam Chair. So can you help me understand why, if we were to sort of implement this recommendation, why to expand the scope of the CON process, why we would still need the regulatory process?
Well, I think that's certainly something this committee could consider, is kind of how to make these different pieces fit together. Those are broader regulatory oversight and don't involve just the kind of private equity and ownership issues, is my understanding.
Yeah, I think to Senator Tipping's point, maybe you don't need both, maybe, you know, one, but that's something that the committee could discuss and decide. Okay, further questions? Seeing none, go ahead.
The next is, and this is actually, looks like it's printed wrong here in this portion of the report. We get the. Yeah. Yeah, so just want to get this exactly as we voted on here, but oh no, we're not on that one yet. So no, we have that right. Okay.
Yeah.
So that was fixed. Thank you so much for that. Yeah, yeah. Prohibit any private equity company or real estate investment trust from entering any arrangement with a healthcare entity for the sale and leaseback of the healthcare entity's main campus or primary location to the private equity company or real estate investment trust. So this is one of the practices that was identified in a number of places that led to hospital closure, where they were kind of saddled with this debt. The leaseback of the hospital to itself seemed to be a real issue.
Okay, any questions on that? Did we have any examples of that here in Maine?
We do not yet have private equity ownership or real estate trust ownership of hospitals, but there are some hospitals that have some similar arrangements. And they advocated for this not applying beyond those entities. So this would not, as recommended here, apply to prohibiting hospitals from doing this if they are not owned by private equity or real estate investment trust.
Further questions on that? Representative Flynn.
Thank you, Madam Chair. Just a clarification, what does the last bullet mean? Prohibit any person from interfering. What are we preventing there?
Can you point out where you see this?
I'm sorry, Senator, would be on page 6, third bullet down. Prohibit any person from interfering with the professional judgment or clinical decision.
Oh,
of a
we
licensed
have
healthcare-
not yet gotten to that one.
Oh, I'm ahead, sorry.
Apologies. So we're on page 12.
Okay.
And we're gonna get to that in more detail.
Was this what we're out of order?
No. Yeah, I had flipped back because I had misread something, but the recommendations are repeated twice. They're just in the bold sections at the beginning, and then they're bolded with additional comments.
Thank you.
In further pages.
Thank you.
I think we're ready. Go ahead.
All right, the next recommendation is to prohibit any transaction involving a healthcare entity in which the ratio of debt to equity is greater than 50%. And that is a pretty straightforward and simple line there, but I think that alone would prevent a lot of kind of the worst case scenarios that we've seen across the country. And by going after the practice instead of the entities themselves, you know, saying we have this issue with private equity, instead trying to regulate the practice, it can address it no matter what these entities are called. They may not be called private equity or real estate investment trust, but if they're doing the same things, then that's a problem. And this is the practice that's often led to hospitals being quote unquote bought, but kind of bought with their own money, loaded down with debt, and then that has led to their bankruptcy and closure.
In Dr. Song's presentation to us, his presentation that's available to you all does a really good job of laying out how the money sort of moves in these debt and these purchases where a lot of debt is loaded onto the entity that's being acquired.
Okay, any questions? Representative Clutch.
Thank you, Madam Chair. Rep. Foley, I was just curious if you could help us understand the opposition arguments on this one.
Yeah, thank you for the question. My concern was prohibit. I mean, there may be a circumstance where it may be of some better opportunity for a hospital to save itself or to continue providing services. But when you say prohibit, it gives you no opportunity. It gives you no, and plus I also felt that with all the other recommendations we had regarding equity firms, that there's enough oversight and review going on, and this would just be another layer. But I didn't like the prohibit portion of it. I felt options should be available if it makes sense for it to happen. So that was my only concern about it.
And I would just say on this, I mean, there were a lot of metaphors used about like how you rescue a sinking ship and things like that. And you do desperate things in desperate times. But I think the majority felt that this in particular, the specific practice would be like putting another hole in the ship at that point when it's already in trouble.
Who's saving the kettle of worms is what I want.
There were a lot of metaphors that we discussed.
Representative Alford, did you have a question?
Thank you, Madam Chair. I'm just curious, is it appropriate in this setting if we have a question for Representative Foley to direct a question to him? Or should we direct our questions
No, I
to the
think,
chair?
I think it's fine because he was on the commission unless you have a
Okay.
problem. Yeah, yeah. He was
First of
a
all-
commission member.
First of all, I forgot to thank all three members. They're sitting with us today for their amazing work on this report. I think it's really outstanding. And I'm curious about Representative Foley, your comment, your concerns with the word prohibit. Did you suggest another term that could be used in lieu of prohibit during your deliberations? Or was there another term that you would have been amenable to? I'm just curious.
I think part of my concern was there's already in some of our recommendations, there's already a lot of oversight of these sort of transactions. And I didn't think that having, so I was in favor of those oversights. But when you got to the sinking ship, I just felt that, at some point in time, you may be able to bail out a little quicker if you have the right options. So prohibit to me says there's nothing you can do. You let it go. And I just didn't feel that was a position that it may be a position you have to take, but you should at least leave options open in case there is a better opportunity to save it from sinking totally. That was.
Thank you.
Any further questions on that one? Representative Alford, if you could turn your mic off. Representative Clucci, did you have a question?
Yeah, just following up on this one I mean, I know we're gonna get to bill discussions, but was it discussed to maybe that instead of a prohibition, having this one trigger a without approval of some process? Was there a discussion of that?
I'm not sure that was specifically discussed. I think the idea here, and this actually started on our very first meeting in the Hospital Association's recommendation that we not outlaw private equity in general, but instead look at some of the worst practices. We did that over time. But on this one, this is something that we believed the majority should be prohibited. That it is not, at that point, a real legitimate transaction that is, beneficial at all to the hospital or to the community that it serves. It's just a money-making scheme at that point if you load that much debt onto an entity.
Further questions? All right, if you want to.
All right, now we're moving on to the one we already heard about, prohibit any person from interfering with professional judgment or clinical decision of a licensed healthcare professional with independent practice authority. So this is another one that the committee can consider a number of different potential ways of addressing this. And there's actually in the appendices a few different laws from different states that go about this in different ways. But the idea here is that we heard from a few different experts and from individuals that had experienced this in other states that some of these specific companies, private equity and real estate investment trust firms, had interfered with the professional practices of especially physicians, had them changing billing codes in ways they felt were close to the line in terms of being ethical and not, and making money in some ways that may have been harmful to the patient's care.
Questions on that? Look like you're pondering, Representative Malcolm.
That's Appendix D if you want to look at the what's done in other states.
Yeah.
We have, and I'd say I believe that we have that as a professional code of conduct thing in Maine, but it's not anywhere in statute.
Representative Clucci?
I was just gonna ask, thank you, Madam Chair. I was just gonna ask, like, how does that fit with, like, requirements for like prior approvals and stuff like that? It feels like it's murky, but is there a clear distinction?
So I think that would certainly be part of the conversation. I mean, I think what we were concerned about here was kind of broader, could certainly include pre-authorization requirements. And I know there's a bill waiting for funding on that as well.
Other questions? Seeing none? Want to go on?
All right. We have a couple final recommendations here, kind of our catch-all broader scope category. The first is to recommend that the legislature reestablish statewide healthcare service planning by increasing coordination and information sharing between state agencies responsible for community health needs assessments, regional public health planning, and implementation of the Rural Health Transformation Program. And this is basically the reestablishment of the statewide planning process for healthcare services that has existed in the past.
Questions on that? None?
To the maximum extent possible, recommend use of federal grant funding through the Rural Health Transformation Program to support the sustainability of rural healthcare providers. Maybe this goes without saying, but that money is now coming to Maine and things have actually progressed a little bit since we've made this recommendation. But I think the concern here was that Maine, by certain definitions, our entire state is rural. And that we wanted to make sure the real focus was in those areas that have been hardest hit by closures and are most concerned about the provision of rural healthcare.
Questions? Seeing none?
Prohibit provider non-compete clauses and non-disparagement clauses in contracts with licensed healthcare professionals. So this was identified as a practice of some of the entities that we were considering needed additional regulation, where they have non-compete clauses, especially for healthcare professionals, that prevent them from going and working either on their own or for another provider in the immediate area, and that could lead to professionals not coming to Maine or not being able to stay in practice in Maine over time. So this is actually one area that I had a little bit more knowledge of as we've considered some of these issues in the Labor Committee as well. And we passed a law last term that did the same for veterinarians.
Any questions on that? Representative Matheson.
Could you drill down a little bit on that? It seems extremely broad.
Yeah, so not to get into the whole history of non-compete clauses here. The whole idea there is giving more agency to providers to be able to practice how and where they want to, and not have that choice limited by their employer. Most employers, and we heard from hospitals there, they're saying we wouldn't do that, but that we have seen that practice in some places. This was prohibited on the federal level under a trade ruling under the previous administration, but unfortunately that has been now rescinded, fortunately, at least in my eyes. We also passed a similar bill in the last term that would have prohibited non-compete for everyone, and that was vetoed by the governor.
And I think we heard testimony too, or from the experts, just regarding especially rural healthcare, how if you can't practice within 25 miles, how that really can affect access for rural areas for providers.
Representative Chimino.
Thank you, Madam Chair. May I ask Representative Foley what the opposition was to that one?
I just felt that I didn't think it was something that our commission should have gotten involved with. This is a labor issue, and not really a healthcare access issue. And that's why I just felt that it should be a discussion regarding labor agreements and not healthcare agreements. So that was my opposition to it.
And I would just say I have some agreement with that. I did not propose this one, for the record. And I believe that if the committee did report out legislation on this, they might want to involve the Labor Committee.
Further questions? All right, moving on.
And the final recommendation here is recommending that the legislature consider the creation of a task force to study the demand for long-term care to determine the appropriate number of long-term care beds and increase nursing home bed capacity statewide. So obviously this is a big and ongoing issue and one we've heard a lot about. This was a specific recommendation about perhaps a next step to address some of those issues. We had a huge scope as a commission and we're trying to figure out some actionable next steps here. So this doesn't solve the problem, but provides at least one path.
Questions on that? Representative Olson.
And I think that recommendation is a little bit weak in the area that it only addresses need. It doesn't address costs and things like that. I mean, the biggest issue that we have on the long-term care side is the financial side. And until, unless that task force was tasked with looking at both sides of that coin, I think it's a lopsided agreement.
Yeah, I would say I appreciate that. And I don't think the commission members, not to speak for everyone, would want that to be limited in that way.
Questions? So Representative Boyer, you are on the opposite side on this one. So we keep putting Representative Foley on the
Oh, yeah, that was
hot seat as far as what
I know, it
his
was-
opposition
I
is.
look
It
real
seems
bad on
only
this one.
fair. We should ask you the same thing.
Yeah. No, my thought on why I voted against it was not that I don't think it's important, but I thought that one, maybe it was outside the scope of our duties on the commission, and two, it could be pulled into the statewide health planning that we had already recommended, was sort of my thought on voting against it.
Thank you.
So,
Right.
do we want to go through
Anything else you wanted to say, Senator Tipping or Representative Boyer?
We just really appreciate you having such good questions and considering all of these recommendations. We have a couple of things on the yellow sheet here. We wanted to make it as easy as possible for at least some pieces of this to be acted upon quickly. So we asked the analysts to put together some potential very draft pieces of legislation on some things that we felt were kind of self-contained and could move a little easier, if I'm saying that right. Maybe not the review one.
Maybe
Yeah,
not the
okay,
review
yeah,
one, but.
yeah.
Yeah, not the second one.
Not the second one, but others. And the second one is much narrower than what we have seen in the past.
Yeah. Do you want to go through them individually or just say people can look at them?
I guess we could ask the chair. Do you
I
want
mean,
to
if it helps you answer that question, our process is going to be that we are not going to take up whether we're going to report out legislation today. We're going to give people a chance to really review the report, look at this legislation. I would expect when we do meet to decide what, if any, legislation we're going to report out, that Colleen is going to walk us through this. So, I mean, you can do it, but I would have full faith that Colleen will.
We also have full faith in Colleen.
I think that's
And
unanimous.
maybe the only thing I would say is that we didn't mean by having these particular parts drafted to say that you shouldn't act on any other parts just as quickly. These just ones seemed like ones where there was something written already or that something to build off of where we could at least get things moving for you so you're not writing legislation in the middle of the session here.
Much appreciated. And again, the burden would fall on Colleen in any event. Anything else? Looks like it. All right. Thank you very much.
Thank you.
Thank you. Oh, great. Okay. Thank you, Edna. So hungry. So we are now going to transition and open the public hearing on LD 1890, an act to facilitate the development of ambulatory surgical facilities by exempting certain facilities from the requirements to obtain a certificate of need. Representative Foley.
Good afternoon, Senator Bailey, Representative Matheson, and fellow members of the Joint Standing Committee on Health Coverage Insurance and Financial Services Committee. I am State Representative Bob Foley and I represent Senate. I represent, well, that goes back a ways. I represent the citizens of District 145, which is most of the town of Wells. I'm here today to introduce a bill that was carried over from the last session, LD 1890, an act to facilitate the development of ambulatory surgical facilities by exempting certain facilities from the requirement to obtain a certificate of need. I've submitted an amendment that replaces the original bill and title, setting a new monetary limit that triggers a certificate of need review rather than a complete exemption. The certificate of need law was updated in 2012 and set new dollar limits on certain types of medical facilities requiring a certificate of need review. One such category was for new healthcare facilities, which include ambulatory surgical centers, among other similar standalone treatment facilities. The established limit was set at $3 million in 2012. Unlike the other categories, new healthcare facilities were not indexed to the annual adjustment based on medical inflation. As a result, despite the increased cost of construction, medical equipment, and the related materials, the $3 million limit still exists today. My amended proposal establishes a new limit set at $5 million and establishes and indexes it going forward, like the other categories within the certificate of need law. Why $5 million? I have included a chart with my testimony for you folks of how I calculated the $5 million based on the starting limit of $3 million and calculating the compound medical cost in inflation index from 2012 to 2025 with an average of 3.9%. I used the 4% to round it up. For 13 years, I came up with 4.99 million. So I rounded to 5 million. Why is this important? Ambulatory surgical centers provide outpatient medical services at a considerable savings compared to hospital surgical settings. One of the drivers of today's insurance premium increases is the rising cost of medical treatment. I've attached for your review a white paper written by Dr. Brian Walton, an economic development strategist and a distinguished professor of business and innovation at Hudson University. His research concludes that encouraging the development of ambulatory surgical centers throughout the country has led to significant savings in the healthcare field, increased timely access to medical procedures, and expanded access to rural underserved communities. My own research using the Maine Health Data Organization figures suggests similar economic findings expressed in Dr. Walton's research. I reviewed 3 outpatient surgeries, and the findings are as follows. An arthroscopic of the knee, the main average was 20,692 with a high cost of 36,304 in a hospital surgical center and a low of 8,611 at an ambulatory surgical center. That was a savings of 58%. Knee replacement, the main average is 49,676 with a high of 66,694 in a hospital surgical center to a low of 28,230 at an ambulatory surgical center, a 43% savings. And hip replacement, main average was 50,865 with a high of 64,035 at a hospital surgical center with a low of 32,671 at ambulatory surgical center, a 36% savings. Dr. Walton found that by increasing the limit under the Certificate of Need statute to reflect today's costs will encourage competition and expand rural access without sacrificing quality of care. In his report, Dr. Walton notes that New Hampshire recently dropped the Certificate of Need process and saw several new ambulatory surgical centers facilities developed in many rural parts of the state, especially in Grafton County. Vermont also changed its Certificate of Need laws regarding ambulatory surgical centers and raised the limit to 10 million. In a March 8, 2024 report from the American Academy of Orthopedic Surgeons, it was found that there was on average a 21% savings between procedures performed in an ambulatory surgical center versus a hospital surgical facility. If we are to address the cost of health insurance premiums, we must start to drive down the higher cost of medical care where possible. Ambulatory surgical centers are but one answer. Also in the category are independent radiology centers, kidney disease treatment centers, rehabilitation facilities, cardiac catheterization centers, and independent cancer treatment centers. I've told you of my own story when I needed an MRI on my shoulder, which my insurance company denied, and I inquired of the hospital the cost would, for me, if I paid it out directly, the cost was $2,100. I then contacted an independent radiology center to inquire about what my cost would be if I were to pay it myself, and my cost was $245. My proposed amendment will assist in the development of all of these facilities throughout Maine. You'll find in the final report of the commission that we just talked about, that recommendation that this category under the Certificate of Need law be raised and then indexed to the future, as all other categories, thus my amendment version of the original bill. I thank you for your consideration, and I am happy to answer any questions you may have, and I hope that you'll agree that facilitating an expansion of ambulatory surgical centers in Maine will benefit the consumers of healthcare services that these facilities can provide and will help draw down the costs of healthcare.
Questions, Representative Matheson.
Thank you, Representative. In Maine, what is the ownership of these ambulatory centers? Who principally owns these?
Anybody can order them. Matter of fact, there is a hospital, a medical facility or medical entity is building one of these facilities in southern Maine right now. There are, I know that in New Hampshire, there's a private company that develops these and leases them out to medical groups. So there's the law doesn't really talk about the ownership of who has the ownership of the facility.
So this is definitely it could be an ownership by a local physician. It could be an ownership by an outside entity that comes in that owns this nationwide. How has it impacted the hospitals that have these settings in New Hampshire in terms of them being able to offer surgical services? If this is,
I mean, I think that, there will be competition to the hospitals, but the hospitals can build these themselves. So there's not really, I mean, hospitals, when they declare that they're a not-for-profit hospital, they get a lot of tax benefit for that. These facilities do not. They're for-profit, and so they will pay taxes based on, their amount of services they provide. But again, there's nothing in the current statute or in my amendment that prohibits hospitals or other. I know that Intermed in Portland is looking at building a few of these facilities in other parts of Maine as well. Currently, they're thinking that through. So, you know, but again, there's currently nothing in statute that does that. And all my bill does is it takes the current statute and raises it to 5 million and index it going forward.
Thank you.
Further questions, Representative Chimino?
Thank you. Thank you, Representative Foley. Is there any compromise in the level of care at the ASCs compared to what's done at the hospitals?
No, these are basically outpatient facilities. Certainly, if there's a patient that is going to require additional hospitalization, they're not going to go to one of these facilities. And so this is really an outpatient type facility performed by the same types of same quality physicians that would do it in hospitals. It could be a doctor that does them in the hospital, but also does them in these facilities. I know that the medical association that's building the one in Southern Maine right now, I mean, they will have their own doctors doing surgery there. It's efficient, it's, you know, less costly, and they can provide those services when they don't need to, you know, take up other spaces within the hospital. It also gives, you know, there's been, you'll see in the white paper that I gave you, there's also an increased ability for more timely access to medical coverage because of these facilities. Not having to wait for a hospital to be able to accommodate a day surgery, for instance. So there are other benefits other than just the cost, but access in rural areas of the state and access to more timely treatment have been findings in the report that the doctor wrote.
Further questions? Representative Flynn.
Thank you, Madam Chair. Representative Foley, thank you. Question: in the increase from 3 to 5 million, are there any metrics on forecasting of what will be invested immediately? I mean, are there people waiting for this?
I suspect that there are entities out there that are looking at this. The cost of going through the certificate of need and the timing has an impact on whether a facility would be built. There is an entity that I know of in New Hampshire that is building these because of the change. Of course, New Hampshire dropped it altogether, so it's a different than what mine. Part of the reason that I chose to not go the full exemption was based on the doctor's report, which said, you should be making changes, but make them gradual so you know the impacts and results of those. And so that's why I decided that it would make more sense to, increase it to reflect the costs over the years and then index it going forward. This committee at some point in time may want to look and say, hey, maybe we don't need to do those, or maybe we want to raise it, and but certainly between 2012 and today, the cost of construction materials, equipment, they've certainly gone up, and to keep it at 3 million certainly is cost prohibitive for anybody to think about building one and be able to provide the sort of savings that we hope we would see in this in the medical field.
Representative Matheson.
Thank you, Representative. I guess it seems like this is fairly lined up with the recommendation of just raising the con balance from the recommendations from the commission. So I guess I'm curious, why carve it out for this entity under con law? Why just this service?
Well, what I did is I amended the con law. So my change would impact all of the facilities that come under the new medical facilities, the radiology, cancer, all of those would increase to 5 million.
I understand.
Yep.
Thank you.
And that was kind of my question. I didn't see where this was limited. I mean, you keep talking about ambulatory surgical facilities, but
I mean, that's
your proposed amendment is not limited to.
It's not.
just
I mean,
those.
my bill started out just looking at that.
Right.
But as I looked at my amendment, I said, if we kept it simple and all we're doing is amend the existing statute and just raising those numbers, that's all my bill does.
Right, so, but it's gonna apply to more than just ambulatory
Yes.
surgical facilities. Okay. Representative Clucci.
Thank you, Madam Chair. So I just want to make sure I get this real, real simple. So is your bill is basically similar to the first recommendation that was unanimous from the report?
Correct.
There's
Although-
nothing different, really?
No, it really,
Okay.
it looks at increasing this category within the certificate of need law and indexing it going forward.
Perfect. Okay, that's how I understood it. I just
So it
wanted-
is different in that he goes up automatically to 5
Right,
million
right.
and then increases it, whereas the commission's recommendation was just to do the medical services indexing,
Right.
which
Okay.
they said was about 4.2 million.
Right.
Yeah, mine's a little bit higher, other than, I took the whole category of medical inflation.
Okay, thank you. Thank you.
Further questions, Representative Arford.
Thank you so much for bringing this up. This mic. Thank you, Madam Chair, and thank you so much for bringing this bill to us. And my question regards the quality of care. I know a little bit about this, and what I know is that, in fact, these freestanding facilities, from personal experience, as well as other experience reported to me by people who work there, they are oftentimes not paid at the same rate that a hospital-based facility would. So therefore, they're working with less money to operate their entity. And therefore, the way in which they operate it may or may not be different than a hospital-based facility. So when you talk about, so that's when I start to be concerned about quality. Who's ensuring the quality? If you're hiring one less person because you're not getting as much income coming into your facility than a hospital would, or if you're doing whatever you're doing to save costs, how is that impacting the patient? So what type of information, I know you talk about this report, which I have not yet been able to read, but how have you considered how these freestanding facilities may, in any way, impact the quality of care delivered to patients? It may be better. It may, I don't have the assumption that it would be lower quality. I'm just wondering what you learned about that. And if you've taken that into consideration in the way in which you have written and proposed this bill.
Yep. I think you'll find in the report that I included, that the doctor finds in his research, and his research is countrywide, that there has been no decrease in the quality of care. Obviously, if you're going to be in the business of providing medical services or any services, you have to rely on the fact that you're providing a quality service so that people, will either recommend or come to you, and most of these facilities are going to be staffed by doctors that are already associated with a hospital or some other medical center. Like I say, if an Intermed decides that they're going to build these facilities, they're not in the business to shortchange medical treatment. I think if you look at the Health Data Organization data, there was no noted decreases in customer satisfaction in looking at the quality index for ambulatory surgical centers versus hospitals. They were pretty much static in the same. So again, I haven't seen any evidence to say that there was a decrease in inequality. I just, again, I think that if you're going to open one and not provide quality, you're not going to stay in business very long.
Well, thank you so much, and I will do my best to look through the report before the work session.
Yep.
Thank you.
Further questions? Being none, thank you
Good.
very much.
Thank you.
Anyone else wishing to testify in favor of this amended bill? Should we run a timer?
Yes. Especially where you guys are.
Hello, my name is Elizabeth Pierce and I'm from Yarmouth. Good afternoon, Senator Bailey, Representative Matheson, and members of the committee. My name is Liz Pierce. I am a board-certified otolaryngologist, also known as an ear, nose, and throat specialist, and I own an independent medical practice. I'm submitting this testimony in support of LD 1890 and its amendment on behalf of the Maine Medical Association and the Maine Osteopathic Association. We recognize that the amendment expands the bill's scope to all healthcare facilities, which we support, but I want to speak today about how this would affect ambulatory surgical centers and surgeons. Like many Maine physicians, after 10 years of training away, I returned home to help my community. I was hospital employed for 7 years. Then 3 years ago, I opened my own independent ear, nose, and throat clinic to offer a less hurried, more personalized experience, more personalized option in an underserved specialty. However, as a solo surgeon, I have personally experienced the uphill challenges of obtaining surgical privileges at the very few hospital-based surgical centers in our state. These challenges delay medical care for Mainers. I currently perform all feasible procedures in the office, a needed benefit for our aging population. Still, if a patient ultimately requires general anesthesia, I am unable to offer nor perform all needed surgeries within my capabilities solely because operating room access is limited, particularly for small practice owners. Ultimately, patient care is unnecessarily delayed and medical costs increase. Increasing the certificate of need threshold will expand opportunities for more surgical centers, improving Mainers' access to timely and needed care. I would like to raise a few points for the committee's consideration. First, Maine's current threshold of $3 million is economically outdated. We sent an email to our independent practice section and received a resounding response that construction far exceeds this threshold. Surgical centers have strict criteria and standards for ventilation, instrument sterilization, anesthetic gas, oxygen, suction configurations, and related areas. Such systems also require calibration and ongoing certification, which increases costs compared to commercial or residential facilities. Additionally, to justify the high cost of sterilization equipment and facilities, as well as a post-operative recovery area, it makes sense to have at least 2, ideally 4, operating rooms in a small ambulatory surgical center. For reference, the current outpatient ASC in Scarborough has 10 operating rooms. Furthermore, my husband, who is here, owns a design-build company and will provide testimony on the current financial climate to better help you understand the exact costs involved. Ultimately, $5 million is appreciated, but it could be increased further. Second, extensive national data demonstrates the financial, safety, and quality benefits of ASCs as an alternative to hospital-based surgery. Hospital-based surgery is an integral part of the healthcare delivery system, but ASCs often allow for more targeted patient care. For example, I've performed surgeries in both locations and have found that ASCs are often more streamlined for many reasons, one being because everyone is motivated to complete cases and finish the day on time. In contrast, at the hospital, another shift is always coming in. The regulatory relief in LD 1890 would enable the growth of ASCs, a necessary component of resolving our health infrastructure. Finally, we have a request for an additional amendment. We appreciate the original bill language, which includes the expansion of ASC. The proposed amendment is only for new healthcare facilities. We request that the language be restored in order to support existing ASCs and other healthcare facilities to expand. The existing facilities support their communities today and deserve the opportunity to add procedural and surgical rooms. We look forward to a broader conversation about reforming certificate of need regulations following the commissioner's recommendations. We will reserve our additional comments until then. Thank you for considering the views of Maine's physicians, and we hope you will support LD 1819 and include the requested amendment. I'd be happy to take any questions.
Okay, thank you. Representative Boyer.
Thank you, Madam Chair. Can you just give me a high level, this is maybe a naive question, but what are the uphill challenges of obtaining surgical privileges? And just like a high level overview, please.
So Maine is a very underserved state, as you probably know, and there's a lot of specialists, most of whom, for example, I'm an ENT, are hospital employed. There's a very, very small number who are actually independent. And so to have privileges at one of the large hospitals, to therefore have operating room access, there's an extremely somewhat arcane and archaic bylaws and rules with ways you, in a way, have to sign up to potentially take more coverage and take on more patients than you had planned to do. Many of us going into independent medicine are saying we want to have, we want to stay in Maine and practice as long, as we're healthy, not get burnt out by the system. And so therefore we want to have a work-life balance, and taking call for essentially the whole state for a week at a time doesn't lend to that. But right now, getting hospital privileges, it's very difficult to not have those expectations and bylaws in place.
Thank you.
Further questions? Representative Clutch.
Thank you, Madam Chair. You might have mentioned this already. Do we have surgical centers like outside of the hospitals in the state? Like a bunch of them?
We do. We have there's small ones, most of which have about 2 operating rooms, plastic surgery. There's some gastroenterology, some of the orthopedic locations. However, for ophthalmology, urology, ear, nose, and throat, and gynecology. In other states, I have many fellow residents that are in all different states. Often those are outpatient day surgeries performed in these, 6 to 10 bed surgical centers that right now do not exist, that each specialty would need to have their own, is just the current status.
Thanks.
Further questions? Representative Arford.
Thank you, Madam Chair, and thank you for being here with us today. I'm curious, say on a monthly basis, how many surgeries, it doesn't matter what kind, could you report to us that you are unable to perform because of these challenges that you're discussing with us?
And I thought that might come up. So in my practice, I have a great team who sort of goes through all the referrals, and we are very candid with patients that right now there's certain surgeries, tonsillectomy, ear tubes in infants. Well, that we can do in the office, but tonsillectomies, cancer biopsies, thyroidectomies, parotidectomies, surgeries that people have to be asleep, that we screen those patients ahead of time and then tell them, unfortunately, if we look through the records, if there's any chance it might be a surgery like that, we're candid with them. So to answer your question, at this time, there's probably, and to be honest, a lot of people just want to go to Boston. If I do say you need surgery, they say, I'm not going to wait 9 more months. I already know the next available at so-and-so hospital is 9 months from now for a consult. So then the care leaves Maine and literally goes to Boston. But on average in the month, now with all those parameters in place, it's probably about 10 a month. And I do a lot more in the clinic than most, just with preparation and, prepping a patient and local anesthetic, you can do quite a bit with less general anesthesia, which does help our brains prevent dementia. However, in the beginning, it was really hard for me to know that I was to keep doing what I wanted to do and stay true to this path, that I was going to probably not do thyroidectomies, not do some of these big cancer cases and surgeries, because those have to be done under general anesthesia. So there's a lot that I'm currently not doing, including whole categories of more neck and throat surgery.
Thank you for that question. I appreciate it. And the other part to that, and I may have heard you incorrectly before, but I heard you saying that you would do more hot surgeries in hospitals if you could access the facility within the hospital that would allow you to do these things that you cannot do.
Great
So I'm also curious as to how many surgeries you're not able to do that you could do in a hospital, but you cannot get the space in the hospital to do it.
Thank you for that question, because it's a good detail. In the very beginning, when I first started the practice, I was still, saying if I can get OR time. I wasn't planning, I don't ideally want to do the big, need a hospital stay for a week type procedures. You need a whole team for that. And but the outpatient ones, what we know in surgery is if you are not doing, you know, surgeries day in and day out, your skills are not, especially when you're working around patients' nerves and airway and those things, that your skill set does dwindle somewhat. Granted, it's muscle memory. So what's been really hard is even 2 years ago, I would have said, as soon, you know, if I can get that hospital, I'll be doing more thyroids, I'll be doing more parotids, but it's been 3 years since I've done those. I'm sure, you know, they say it comes back like a bike. But at this point I've really shifted, which has been a good thing. I'm doing a lot of really, you know, non-invasive procedures in the office that are very, not offered much in the state, as a pivot. But there are, it has changed the scope of what I'm able to practice. And I feel I was very well trained, trained well, came back to my home state. In 7 years of taking call, I only sent one person down to Boston on call, from Presque Isle all the way down. So at now, if you were to say, if, you know, we can get a surgical center that bunch of different specialties in, I probably would not need to do OR cases in the hospital. I prefer outpatient. It's better, honestly, for everybody, the team, from the scrub techs to the nurses to the patients, everybody, to be honest, seems happier in a surgery center.
Thank you very much.
So,
Further questions? Seeing none, thank you very much.
all right, thank you.
Anyone else wishing to testify in favor? And just so you know, now that we've got it up and running, we will be doing a 3-minute clock. So please try to limit your testimony to 3 minutes or under.
Good afternoon, Senator Bailey, Representative Matheson, members of the HCIFS committee. My name is Trevor Putnaki. I'm the CEO of the Healthcare Purchaser Alliance, and I'm here today to testify in support of LD 1890. I would start by saying, you know, when certificate of need programs were first created decades ago, at least a big part of the rationale was that we didn't want oversupply. They thought oversupply would lead to overutilization, and that would drive up costs within a market. Over the intervening decades, we've had numerous studies show that utilization has remained relatively flat, and that the real driver of increasing costs in the healthcare system is price. And so I think at a very high level, it's important to think about ways we can increase competition within the healthcare market in Maine. And I think Representative Foley's bill is a good way to sort of open up the market a little bit to create more competition, which puts downward pressure on price. In 2024, there was an empirical assessment of CON that found that 60% associate CON with higher spending per service, while just 7% associate CON with lower spending per service, and the rest had negligible results. I think we've seen not conclusive results out there, but a lot of evidence to show that CON process does more to increase costs within a market because it restricts competition within a market than it does to actually control costs. And as Representative Foley and others have mentioned, there has been an increasing movement across the country with states repealing their CON processes or increasing thresholds for CON review. New Hampshire repealed its CON program in 2016. And one of the things we heard last year when we were discussing Representative Foley's bill in Anthem's testimony is that there are a lot of surgical procedures that are a fraction of the cost in New Hampshire right now that they are in Maine. So I think, again, you know, it's not conclusive evidence. It's not a study, but I think anecdotally we can see that where there's more competition in markets, we see lower costs. As noted, the amended version would increase the threshold from 3 million to 5 million for new healthcare capital expenditures subject to CON process and index the threshold to CPI thereafter. The threshold has not been increased in many years, as others have noted, and the proposed update is consistent with the recommendation from the Maine Commission to evaluate the scope and regulatory review oversight over healthcare transactions that impact the delivery of healthcare services in the state. What a great name. That is something, a commission that I did serve on as well and supported that recommendation. I will also note that research on independent ASCs shows that they deliver services at lower price points relative to hospital outpatient services. I have a couple examples of my testimony. Prices paid in hospital outpatient departments were 54.9% higher than those charged in ambulatory surgical centers. For colonoscopy, 44.4% higher for arthroscopy, and 44% higher for cataract removal surgeries. I would also I see I'm out of time here, note that a 2024 study found no evidence that CON repeal is associated with hospital closures in rural parts of the state. I know that's a really important consideration that people are thinking about. We were unable to uncover any studies or evidence that back that assertion up. So thank you for the opportunity to testify on this bill, and thank you to Representative Foley for introducing this bill. Appreciate it. Happy to take any questions.
Okay, questions from committee members? Representative Arford.
Yeah. Thank you, Madam Chair. Quickly, I know that you're aware of the fact that a few years ago, overtreatment was a very big concern in the
Still is.
healthcare industry. And we've sort of gotten away from that post-COVID. But because I know that you are somewhat knowledgeable on this, is there any concern that if we were to build and allow more of these outpatient, especially the ambulatory surgical centers, that we might be seeing a move towards overtreatment because they'd have to be doing procedures to pay for the facilities? Do you have any concerns about that at all?
I don't have any serious concerns about that. I mean, I think overtreatment is still an issue in America. You know, we have prior auth that mitigates some of that. You know, granted, there are issues with prior auth that we've all talked about here before, but I think that does a good job of it. What we're talking about here really is just price, right? Price in the market. And study after study shows that utilization has remained pretty much flat for the last 10 years, while price is what's driving costs up. So if a policy brings to market lower price options, I think that we'll see healthcare costs mitigated somewhat by that. I don't think that having more options necessarily would increase utilization, especially when people are already waiting long periods of time to get a lot of these services. I could say maybe eventually, if you have just a ton of services and people are trying to justify it, maybe you get some level of overutilization, but there are mechanisms in place to protect against that overutilization. So I'm not sure. I mean, I don't think there's ever like a perfect policy that I've seen, but I think on the balance, it'd be better to have more supply, lower prices, and deal with overutilization through other means, like perhaps a more streamlined prior auth process.
Thank you for that.
Thank you.
Further questions? Seeing none, thank you very much.
Great. Thank you all.
Anyone else wishing to testify in favor of the amended bill? Oh, you want to go first?
Go ahead. Didn't realize it's.
You're next. Sorry.
Okay.
I'm Russell Pierce from Yarmouth. Good afternoon, Senator Bailey, Representative Mathis, and members of the Joint Standing Committee in Health Coverage, Insurance, and Financial Services. I own a design build company here in Yarmouth, Maine, and for the past 11 years, ranging from residential to commercial projects. I'm submitting testimony to support the amended LD 1890. I aim to provide perspective in the construction cost standpoint, particularly in the current climate. Over the last 22 years, I've been a project manager of all construction sizes, from schools to shopping centers to medical clinics to custom homes. I've professionally and personally seen how the construction climate in Maine has changed over time and how it compares to other parts of the country. For these reasons, I strongly support LD 1890 for the following reasons. First, Maine's construction climate in 2025 can best be described as active and stressed by cost pressures. During the pandemic, I saw material prices increase significantly, at least 20 to 30%, and unfortunately, prices have, for the most part, held. Volatile and elevated prices are driven by tariffs, supply chains constraints, inflationary pressures on key inputs like lumber, steel, mechanical systems, higher input prices and transportation costs continue to squeeze margins. As one can imagine, that a business cannot operate in a negative, so these costs are passed on to the client, increasing the total cost of the project. Informally, I spoke with a main builder quoting a surgery center addition, adding 2 ORs. He noted that quote was approximately 3 million pre-pandemic and rose to 10 million post. Secondly, workforce constraints have been one of my largest challenges in Maine compared to other states where I've worked. This likely does not come as a surprise for many of you. Skilled labor remains one of the industry's most persistent constraints. Contractors, subcontractors frequently report to me their ongoing difficulty recruiting, retaining quality carpenters, electricians, and other trades, even as firms offer competitive wages. When it comes down to waiting for a licensed in-demand professional, being an electrician or a physician, etc., time is money. The labor scarcity impacts scheduling, increases cycle times on projects, and raises carrying and overhead costs, effectively increasing the overall project pricing. A modest 4,000 to 6,000 square foot ambulatory center can exceed 2 to 3 million in equipment. Core surgical diagnostics diagnostic equipment routinely add 2 million in capital costs. As a result, the current threshold captures minor renovations, safety upgrades, and basic outpatient expansion, subjecting anything larger to lengthy regulatory review. Finally, I want to note that I am sure the 5 million is appreciated, especially since it will be adjusted for inflation. However, I think the amount threshold could be increased to 7.5 million. I hope you support LD 1890 and happy to answer any questions.
Okay, thank you very much. Questions from committee members? Seeing none, thank you. Anyone else wishing to testify in favor? Thank you for your patience.
You're welcome. Thanks.
You can go ahead.
You want me to go ahead?
Yes.
Okay. Good afternoon, Senator Bailey, Representative Masterson, and distinguished members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Bonnie Vaughn, and I reside in Cumberland. I'm Executive Director of the Kennebec Valley Family Dentistry Center, a nonprofit dental center serving all ages, including more than 80% Maine care. Our services include diagnostic, preventive, restorative, and extractions. Our center is located right across the river in the Ballard Center of the old Maine General Hospital, 6 East Chestnut Street. What we've seen over the last at least 10 years is major needs in sedation for children and adults for repair of dental services. And so we are speaking in favor of 1890. In 2021, Kennebec Valley started planning and developing an expansion of our current location by adding 5 dental operatories, including 2 sedation rooms, ambulatory surgical centers, to our current 8-chair clinic. So we will be adding, or be a total of 13 chairs right here in Augusta. We did go through the process of submitting the letter of intent in 2024 to the department, and we were lucky to receive a letter from the department in October 2024 based on the dental needs of the area and our plan, our ASC plan. We were not subjected to deep review. I've attached our proposed letter of intent and the response, and I've also included the cost of our center because that may be a concern. I've attached also our floor plan so you'd know what our surgical centers will look like and our structure of our dental rooms. Maine has very few surgical centers for dental care. And so this was one of our motivating forces. So I'm very supportive of this entity, and you may have some questions, and I'd be glad to come to your workshop session.
Okay, great. Thank you. Questions from committee members? Seeing none, thank you very much.
Okay.
Others wishing to testify in favor?
Senator Bailey, Representative Matheson, and members of the Joint Standing Committee on Health Coverage Insurance and Financial Services. My name is Kaylee Shea, and I'm a policy analyst at the Office of Affordable Healthcare. The executive director of our office served on the commission that you heard about earlier, which has recommended the committee adopt very similar changes, which are reflected in LD 1890. The bill, as you have heard, will align the regulations governing new facilities with those that apply to other projects currently subject to certificate of need by increasing the threshold that triggers CON review and approval to establish a new facility and requires that that amount be adjusted annually. In current law, the establishment of a new facility is the only project reviewed that has not annually been indexed to inflation. The increase from 3 to 5 million reflects a retroactive application of the annual adjustment to ensure that these project thresholds are caught up to other expenditures that have been historically adjusted. LD 1890, therefore, will align the regulations governing new facilities with those that apply to other projects subject to certificate of need. Adjusting the threshold to reflect current costs and updating it annually will help ensure that oversight remains focused on projects of significance while taking steps to address concerns about barriers to entry for new facilities, as you've heard much about, with the potential to increase access and lower the costs of care for patients. I encourage you to support the timely and appropriate changes made in LD 1890. Thank you for your time, and I'd be happy to answer any questions you might have.
Thank you. Questions from committee members? Seeing none, thank you very much. Others wishing to testify in favor? No. Yes. Yeah.
Start my timer.
I'm starting it now.
You're already 30 seconds in.
Yeah, I thought I was gonna get a
You're
break when
almost
you
done,
couldn't.
sorry.
That's all right, I can do
Yep,
it.
You're out.
I thought the construction expert and the ear, nose, and throat specialist could go before me. Good afternoon and welcome back. It's nice to see everybody. My name is Dan Demerit. I'm the Executive Director of the Maine Association of Health Plans. We're here today to testify in support of the sponsors amendment to LD 1890. We'd share that healthcare costs in Maine's healthcare systems have changed significantly in more than 15 years since the legislature last updated the Certificate of Need statute as it pertains to the review threshold for establishing new healthcare facilities in Title 22. We support both increasing the capital expenditure threshold for new healthcare facilities and indexing the threshold moving forward for inflation, as the sponsors amendment proposes. And that is consistent with other provisions of the con law. Maine's healthcare systems and its patients need access to alternative sites of care that are high quality and less expensive. We've heard about that from prior speakers today. We will share that healthcare expenditures on a per capita basis from hospitals, according to the Office of Affordable Healthcare's 2024 annual report, have increased 164% since 2001 to 2020, compared to 25% for Maine household income. That's a six-fold increase in community growth in per capita health expenditures in that time. Our testimony provides graphs to the OHC report for your review. We support higher thresholds reflecting. We think the committee should go even further than the sponsors amendment, perhaps. We heard today about different figures and numbers, and appreciated the sponsor sharing the compounding approach to the $5 million. We would note for the committee that while you've heard that New Hampshire has repealed its con laws, Vermont, a little bit further to the west, increased a six-fold increase into its certificate of need for its for these types of facilities from 1.5 million to 10 million just last year. And we heard from perhaps the only construction expert we'll hear from this whole session, prior to me, that it's cost about $10 million. So we're calling for $10 million. If someone's got to be the outlier, we're happy to be it on this case, but we think there's a case now, even stronger case to be made for the 10 million based on prior speakers. We appreciate the work of the commission, Healthcare Transaction Commission, which we call it internally, and in their work, and do think that pointing to kind of more Maine-based, the medical inflation is a national figure, and when you look at the impacts of healthcare spending in our hospital systems, with all due respect to the folks from the hospitals who are in the room, suggests that a bigger increase than just to 5 million may be warranted. Happy to answer any questions and participate in your work session.
Representative Matheson.
Hey,
Welcome back. Happy New Year.
thank you.
I was just curious, I certainly am a big fan of lowering prices. Sorry. Thank you, Chris.
Sorry about that. That's okay. It's probably, you probably didn't need to hear
I heard you
that.
say you were going to support the bill on
No,
unequivocally.
that's
Yeah,
not what I
okay.
said. I said, so I guess what I'm curious about, I mean, con laws, obviously, the history was to try to help with costs, but it also helps with equitable distribution of care. So I'm curious, is there any data out there in these states that have changed their con laws that has identified a change in equitable distribution of care?
Yeah. Equitable in terms of healthcare equity as opposed to, is it?
Well, con laws
Yeah.
certainly are trying to make sure that they offer care that equitably
Yeah.
to all people in rural areas and in throughout the state and all the types of care. So I'm just curious, have these con laws changes decreased that?
Yeah. I'll have to go back and work with my group and see what we can find out, but there've been, we did hear one example, I think it was from Mr. Putnacki's testimony about the impact of cost anyway in New Hampshire, and I guess that doesn't get to necessarily equity. Cost and equity are not always synonymous, so, yep.
Representative Clucci.
Thank you, Madam Chair. So along those lines, as Rep. Matheson was asking, I just want to understand Rep. Matheson's sort of question. Is it similar to like, are we thinking about like, are these new practices going to like not take main care or not take Medicare? And so people will be getting, so you can only go to these facilities if you're getting, if you have expensive insurance, private insurance? Is that the
That's part
concern?
of it, yeah, and also just the services themselves. If someone, I'm just curious, has
Mhm.
there been a change in that distribution of care when the con laws have changed? I'm just
Sure.
curious.
Like, of course, we're talking about the thresholds and not changing the underlying con law in terms of the, once you get to the, I get it, like if you're running projects through that are gonna undermine equity by increasing the threshold, that's certainly a concern, but the bill is proposed, the sponsored amendment doesn't change the underlying criteria that the department will use to assess projects. So, but yeah, we'll see what we can find out. Thank you.
Right. I mean, the bill before us is again, just to increase the thresholds, we had a bill last session. We have a bill every session to repeal the con law, but
Yeah.
I don't want to go down that rabbit hole.
Sure.
Unnecessarily.
Thank you.
And further questions? Representative Arford.
Just very quickly, because
Sure.
I don't want to open up a whole nother thing, but based on what the conversation that just occurred, it is possible then if we were to pass a law like this and there was, let's just say, half a dozen facilities that were now under the dollar amounts, so they could plan the facilities, they could build the facilities, they could operate the facilities without any con review. And it's possible that those facilities could just choose not to accept publicly funded health coverage plans like Medicare, Medicaid, and just take privately insured people.
I don't know the threshold bill before you makes any changes to that in any kind of requirements for how someone would be covered, what types of coverage those providers would have to accept. There are, obviously, no matter what structure they are, whether they're for profit or a nonprofit, they still have economic, realities that they have to try and contend with in terms of doing their work. So that would certainly be a consideration for those providers or the owners of those entities. So, sorry, that is, I don't know, are we a kettle of worms, this committee, or a can of fish? I think it's can of worms, kettle of fish, right? Senator Tipping's actually my constituent in Orono, so I'll have to go over that with him and maybe get him the right. I think we've got it
He
right.
said kettle of worms.
Yeah. It's the fish in the kettle, the worms are in the can. That's how, yeah, I'll straighten it out. Thank you so much for your time.
All right, thank you. Anyone else wishing to testify in favor?
My turn. Your turn, Chris. I wasn't gonna ask it.
I can't believe we got both of them to testify yes on our first bill here.
I know, right?
Starting the new year off on a different footing.
Geez, it feels like just yesterday I was up here. Good afternoon, Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. My name is Christine Ossenfort. I am the Senior Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, and I'm pleased to appear before you this afternoon to testify in support of the proposed amendment to LD 1890. We support this proposal for several reasons. As previous speakers have noted, this is consistent with the recommendations of the commission. The Healthcare Oversight Commission was the shorthand name, of which I was also a member. The threshold, as I think someone else noted, the threshold that applies to new healthcare facilities is one of the few thresholds that is not already adjusted for inflation in the CON statute. Other than new nursing facilities, all other thresholds are adjusted for medical CPI on an annual basis. So this threshold has not kept pace. It hasn't been adjusted in over 15 years. We believe that updating the threshold will provide important opportunities to increase access to high quality, lower cost providers such as ambulatory surgical centers that offer important healthcare services in Maine. These facilities generally provide a better patient experience as well. The cost difference between an ASC and a hospital can be significant. This impacts not only premiums, but also what the member pays out of pocket when the deductible and the out-of-pocket maximum have not been met. As other speakers have noted, New Hampshire repealed its CON requirements nearly 10 years ago. New Hampshire has far more ASCs than we do in Maine, which provides greater choice and increased access to these services. Attached to my testimony, and Mr. Putnaki sort of hinted at it, but I never gave this testimony last year because the bill was carried over without a hearing. But are some examples of the price differentials, both for ASCs versus hospitals in Maine, as well as Maine versus New Hampshire. It also reflects the utilization of those ASCs in the two states as well. Last session, this committee spent a fair amount of time in discussing LD 1152 about right to shop incentives. And one of the reasons that these incentives are sometimes underutilized is because there is a lack of alternative sites of care to which we can direct providers. So adjusting the CON thresholds and making it easier to establish ASCs could help to address that. It could also have premium impacts as well. We looked at the utilization, and this is just our data, in Maine versus New Hampshire. The claims across all carriers, we estimate, could be reduced by as much as $40 million, which would have an impact of about 0.4% on premiums. While we do support the legislation, we would suggest that the committee consider increasing the threshold to $10 million. This could provide increased opportunities. It's more in line with the action taken in other states, such as Vermont. You heard previous speakers talk about how probably $5 million is not enough. And I would also note that, and I apologize, I did not attach it to my testimony, but can provide the committee with copies. The CON unit in the Department of Health and Human Services provides the indexed, the updated figures that are indexed for inflation every year. And for existing healthcare facilities, the statutory amount is $10 million. The current threshold is $14 million. So right now, as if I understand this correctly, you have to be under $3 million to avoid CON review. But if you want to expand your existing facility, you've got a $14 million threshold. It doesn't seem logical that those are so far apart. So we understand that incremental change is may be preferable. So one option would be to increase the threshold to $10 million over time, perhaps go to 7.5, as Mr. Pierce suggested, and then a year or two later, increase to $10 million. And so with that, I am definitely out of time. I'm happy to answer any questions that you may have, and I will, of course, be present at your work session as well.
Okay, questions? Yeah, Representative Clucci.
Thank you, Madam Chair. Can you say, you said that expansion, in statute, what's up to $14 million?
So in the CON statute, the general threshold for capital expenditures is $10 million, but that is a number that is indexed to inflation. I'm trying to combine words. And currently, according to the department's chart, that figure is now $14.7 million.
And you said that's for general,
That's the threshold applies to general capital expenditures for like expansions of existing or a new hospital. That's the threshold. But for ASCs,
Right, it's just new facilities that's currently not indexed to inflation.
Right. I see. Okay, thank you for clarifying.
Yeah. Which I think there's consensus, we need to address that. It's just how to address it. Any other questions? Seeing none, thank you.
Thank you very much.
Anyone else wishing to testify in favor?
Senator Bailey, Representative Matheson, members of the committee. My name is Bruce Garrity. I'm here on behalf of the Maine Automobile Dealers Association, which has its own self-insured program to provide healthcare coverage. Before I make any comments, I would say that I was brought back to years gone by when I heard people starting to refer to con law. That did, and I'm sure Senator Bailey remembers that. That does not hearken off the thought of the certificate of need process, I can tell you that.
that's why I call it CON.
Well, I'll bet every attorney in the room thought the same thing. In any event, I'll try to be brief, and maybe obviously the association is concerned with costs. They're concerned with being able to save costs. They don't have a profit motive, and anything they can do that will hold the line is something they want to support. And I think I have an interesting story to share with you, which I think emphasizes the point about what can be saved. I live in Cape Nettic now, so does my partner. Each of us, within a matter of 2 months of each other, had the delightful experience of having a knee replaced. The only difference was it was my left knee, it was her right knee. And we happened to go to Portsmouth. It's the closest significant center for us. And of course, you've heard New Hampshire revoked its standards. And we had the same orthopedic surgeon. We had the same anesthesiology needs. We had the same physical therapy program in the same company. And the only difference was because of timing, my partner was able to have hers done at the ambulatory center. I had to go through the hospital. My bill was well over twice her bill. And other than the fact that I'm taller than her, I couldn't think of any other differences that would justify that kind of cost difference. So as you look at this, I'd respectfully ask you to think about the impact this can have on savings for those who are providing the health insurance. And with that, Senator, I'd be happy to try and answer any questions the committee might have.
Thank you. Questions from committee members? Seeing none, thank you very much. Anyone else wishing to testify in favor? Great. And we did have 2 people signed up. Are they both there? Yes. All right. So if you want to move Emily over, please. Hi, Emily, welcome. And
Hi,
I don't
thank you
know,
so much.
I don't know if you've been listening, but we do have a 3-minute clock. You probably can't see it from there, but we'll let you know if you run over, okay?
Okay, thank you.
All right, so go ahead.
All right, members of the committee, thank you so much for this opportunity to testify today in support of LD 1890. My name is Emily Amin, and I serve as State Policy Counsel at Pacific Legal Foundation, or PLF as we call it. PLF is a nonprofit public interest law firm dedicated to defending American civil liberties in courts and legislators across the country. Although we are founded on the West Coast 50 years ago, today we are active in all of the United States. As part of our work to protect individual liberties, PLF represents healthcare providers nationwide who want to deliver safe and high-quality care to their patients, but are prevented from doing so by overly burdensome laws and regulations. Often these barriers take the form of Certificate of Need or CON laws. Extensive research shows that CON laws do not achieve their stated goals. Rather, they raise healthcare costs, reduce access to care, fail to improve access for vulnerable populations, and decrease healthcare quality overall. In other words, these CON laws fail to provide any meaningful benefits to the public. And this conclusion is supported by real-world evidence. Roughly 40% of the US population lives in states with zero or very few CON laws, making it relatively easy for economists to compare outcomes. Unsurprisingly, states that make it difficult to open new healthcare facilities consistently experience worse access to care. But recognizing these failures, many states have started to reform their CON laws, which is increasingly making Maine an outlier in the region. In 2025 alone, New York, DC, and Vermont all enacted significant CON reforms by raising capital expenditure thresholds and allowing lower cost facilities to open without navigating the costly and time-consuming CON process. For example, in Vermont, they raised their threshold from 1.5 million to 10 million. DC increased theirs from 6 to 15, and New York raised theirs to 20 million, 30 million, or 60 million, depending on the type of project. Additional reforms have also occurred recently in Connecticut and through procedural changes in Massachusetts. But even closer to home, Maine's only bordering state, New Hampshire, fully repealed its CON laws in 1996. As a result, New Hampshire residents benefit from shorter wait times and lower costs. In fact, Massachusetts physicians routinely refer patients to New Hampshire for imaging services because the appointments are faster and the prices are lower. For these reasons, PLF urges your support for this bill. Raising the expenditure threshold as this bill does would put Maine on track with other states in the region, and most importantly, would help individuals get the care they need. Thank you again for your time and consideration, and I would be happy to answer any questions.
Thank you. Questions from committee members? Yeah, Representative Matheson.
Thank you. Thank you very much. Did you submit testimony in written form by any chance?
I did,
Oh.
yes.
Okay, thank you.
Any further questions? Seeing none, thank you very much. And Edna, if you want to move Kate Endy over. I saw Catherine. I'm like, who's Catherine?
Babies can be like, okay, that's it.
Yeah. Oh, that's right.
She's like,
Maybe we'll get to see how much the baby has grown. We're all disappointed. We were hoping to see how much the baby has grown.
Oh, well, he's right here. So.
All right. Oh, we needed that at 5 o'clock. Thank you for sharing that. Go ahead whenever you're ready.
Thank you so much. Senator Bailey, Representative Matheson, and members of the Committee on Healthcare, Insurance, and Financial Services. I'm Kate Endy, and I'm the Policy Director at Consumers for Affordable Healthcare. Thank you for the opportunity to testify in support of the amendment to LD 1890. I'll try to keep my comments very brief since I know it's late in the day, but I had the honor of serving as a member of the Healthcare Oversight Commission, which you heard from earlier. And as others before have noted, this amendment is very close to one of the recommendations of that commission to adjust the monetary threshold that triggers the certificate of need. As has been noted by others, this has not been updated in over a decade, and $3 million today It doesn't go nearly as far as it used to. And so we believe updating the threshold and then tying that amount to adjust with medical inflation to prevent it from becoming outdated in the future is a prudent step to ensure Maine Certificate of Need regulations are in line with current costs and functioning as they were intended to do. So happy to answer any questions, and thank you for your time.
All right, thank you. Questions from committee members? I think that's it. Thank you very much. Thank you for your patience. And anyone else? And everyone that was on the list. Okay. So anyone wishing to testify in opposition to this bill? Anyone wishing to testify in any way on this bill? Welcome.
Senator Bailey, Representative Matheson, members of the committee. My name is Jeff Austin with the Maine Hospital Association, speaking neither for nor against. Happy New Year. It's good to see you. First, I want to thank Representative Foley for the amendment. The original bill we would have opposed, and we appreciate that he amended it consistent. I believe, I don't know if 5 million is the right number, but consistent largely with the recommendation of the commission. So we appreciate that. As some of you may recall from previous testimony from me on CON, it's a Goldilocks issue for us, trying to find the right balance. You can, in our opinion, go too far and put so much regulation in that it appears you can develop, but you really can't. It's so burdensome that it becomes a barrier. Or we believe you could go too far in the other direction and repeal it. We think it is a worthwhile program. So finding that right balance where there is some review, but it's not so stringent that it becomes a barrier is, we believe, sort of the task for you as policymakers on CON. So we would have testified that the original bill had gone too far in one direction. And so we appreciate the amendment and don't object to it. I'm not going to offer math on what the right inflation factor should be. The effective date for the old law was 2012. So I've heard a whole bunch of different numbers out there, but it was 2012. So inflate it from there, and I think we're okay. I do want to just quickly testify. One of the concerns we have is that we feel there is some sort of misimpression that the threshold is a barrier. It's a go, no go threshold. It's not. ASCs are built with CON laws all the time. Multiple ASCs and other projects are being developed in Portland area right now. So if the testimony were true that 30% of my patients have to leave the state for services and it's 10 months wait for a consult, I believe, I don't speak for the CON unit, but I believe you would probably meet the need standards and what would get permission. It is a regulation. It does have costs associated with it, but it's not a wall. There's some misimpression, we believe, that it's somehow a wall and anything over the threshold is prohibited. It's not. I was not a member of the task force, but I attended it. Not one case was brought forward. Not one. What was brought forward was speculation. And speculation's fair, right? People might self-censor and not bring forward a project. And so that could occur. But no one came forward and said, I had a legitimate project, my patients have need, and we were denied. So I'm trying to be good here. We're not opposed to the bill as amended, and we appreciate the amendment and think we ask you to try to continue to balance the needs and find that Goldilocks spot.
Thank you. Representative Boyer.
Thank you, Madam Chair. Thank you, Jeff, for being here. I'm glad you brought up the ASCs that are being built right now. Can you remind me who owns those ASCs that are being built right now in the Portland area? I just can't remember.
They're
off the
on
top of my
the CON unit website, I believe.
Okay.
I think we can get them. So there's two parts of the website. There's the part where people ask, am I going to be subject to CON? And they get a no, you're not letter.
Yeah.
And then there are others that are subject to CON and they get permission. And I think
Right.
both of those are on the CON unit website.
Yeah, just interested if it's like a major health group in the state or,
I
who's
think it's a
built- who's
range.
built
I
it.
think there's a hospital system one, then there are independent practice ones as well.
Great,
the-
would love that information
The
for the work
pattern you will
session.
see, normally, the pattern you see is that this development is in southern Maine along the I-95 corridor.
Sure.
People aren't rushing to build surgical centers in Aroostook County and Washington County. It's where the money is. But
Yeah, Representative Alford.
Thank you, Madam Chair, and thank you for being here with us. I have a very quick question. Someone mentioned earlier that even, it was a comment, something about like, that hospitals could also build these independent surgical facilities. And
Correct.
how would, do you already do that? I mean, when I picture of a hospital, all your surgical facilities are within your campus. Do you do it? Would you do something, would a hospital build something? I don't know
Yes.
how that would work.
yes. Generally for the convenience of the patient, the hospital's big and in one place. And so if you see that a lot of your surgical patients are coming from 25, 30 minutes away, you might build a surgical center nearby.
Do you have any like that? Are there any that
I
are?
believe there are. We don't track them at the Hospital
Okay.
Association, all the physical locations of our members' services, but I believe they exist, yes.
Okay, thank you.
Further questions? Seeing none, thank you very much.
Thank you.
Anyone else wishing to testify on this bill? Seeing none, I will close the public hearing on LD 1890. And anything else? You do? Okay.
I won't take too much time, but I emailed the committee the final language on the amendment to LD 961.
Oh, you see that?
Yesterday, Representative Matheson's bill, it's unanimous, ought to pass as amended. I can hand out the hard copies, so you can have them and I can put them in the file. But I just wanted to confirm that it's good to be reported out so that it can be taken up, or that was really what I wanted to confirm.
So we can hopefully be the first bill on the consent calendar like we were last session?
I think there was a bill on the calendar today. for utilities,
No.
Yeah, but
Oh.
anyway, not quite. Maybe the second committee.
Yeah.
But-
Go ahead, sorry.
Can I just clarify the fiscal notes language and if you could, I'm just curious, does that land it on?
It will not.
Okay.
No,
great.
it's other special revenue. So it would not, if it moves forward, it would not land it on the special
Okay.
appropriations.
That's what
table.
I thought, but I
No.
want to make
Yeah,
sure.
just to confirm
Thank
that.
you.
Yeah. And as you know, there's an expectation that if this moves forward, the hope is that it could move forward quickly because there's a report back for this actual session for you to kind of move that process forward. So soon, if we can get it reported out of committee quickly, then you can get it on the floor and get it moving. So, okay, great. That was all I needed. I just wanted to
Thank you.
confirm that.
I do have one other thing, but Ed and I want to check with you first. I'm assuming, but I did not check with you, that you would be willing to do snacks again, but we need to get you money. Is that accurate? So
Thank you.
folks, if you appreciate the snacks that Edna gets for us, just contribute to the fund,
Whatever you want.
whatever you can give. Whatever she gets, she will spend, and we will eat.
And we will.
So-
We will eat. That's funny.